Hello, guys, and welcome back to Diabetic Desk pre recorded webinar session. My name is Charity Onyonyi. I'm the founder of the Diabetic Desk. So, Happy New Year! I know I've not talked to you since last year. Yes, so I had an article post last Friday. Where we talked about some of the shifts that are happening or will be happening in the diabetic field this year. So today I want us to talk about how we've traditionally approached diabetes. So this is my own view, my own review. You can leave in the comments of this video. What are your thoughts on my social media platforms? And let's talk. So I'm going to be setting the foundation for why this field is shifting. So I'm just basically going to be diving in each pre-recorded session, which will be happening after every 2 weeks. And if I feel like I'm okay, I'll be bringing in people so that we can also continue with the discussion around diabetes. So, just setting the context for you guys. Um, Previously, I'm not say a long time ago, diabetes care has historically focused on the clinical markers and outcomes. And what do I mean by clinical markers? Those are the things such as blood glucose, HbA1c, weight, BMI, took center stage when it comes to diabetic care. National and global guidelines prioritize measurable indicators, blood glucose, either fasting or random, HbA1c. Those are measurable indicators of how someone is controlling their blood glucose level. This approach has strengthened diagnosis and treatment protocols, but it has also shaped a number first culture in diabetic care. What do I mean a number first culture? We look at the outcomes. What are the numbers telling us? And these days, with the holistic approach of nutrition, it's just not only about the numbers, it also other factors that affect how someone is managing. And that is what I've been talking about on Monday on my case study with Charity, and also on the diabetic desk every Friday. I have an article talking about different types of risk factors, other factors that can affect the management of diabetes, either pre-diabetes, before you are diagnosed, after you are diagnosed, and all that. So I want us to understand this content because this is what we'll be focusing mainly on this particular session. So let's continue with looking at how blood sugar numbers dominated. HbA1c remained the gold standard for assessing control because HbA1c is taken after every 3 months to see how someone is controlling their sugars. A higher HbA1c means someone has uncontrolled sugars. Fasting and random guide treatment decision because when you go to the hospital, mostly if you're not told to fast, your random blood sugars will be taken and then it will guide the decision of the physician, the nurses, the nutritionist at that time. So clinical algorithms are triggered by glucose threshold. Monitoring focuses on what levels are reached. Less emphasis is placed on why those numbers change. So my main insight on this slide is numbers describe the state and not the cause. Because when I was collecting my data, we could find someone has all the knowledge, has a positive attitude towards management of diabetes, is aware of what is needed for self-management of diabetes, but the numbers are still high. The person has an HbA1c of 10%, a fasting of 12, and then a random of almost 30. So you keep on wondering, is there a loss in translation from the numbers to what the person is saying to what is actually happening? So, weight centric thinking. Why did I have this slide here? Weight loss is commonly framed as the primary management goal, and this, remember, is the traditional approach when it comes to management. This is what I feel like some is still being done because I've been out of practice for a while. So, what I read and what I know is what I get from webinars that I attend and also interacting with people who are practicing in the hospital. So BMI, I don't know, guys. Maybe you can tell me in the comments. Is BMI still used? Like, anyways, let me not start with the BMI. I think I'll just have a session where we talk about the pros and cons of BMI. Despite knowing its limitation, we all know the limitation of BMI because you will not compare an African a body a body of someone in the states, or someone in the Asian, someone in the Indian. It's it's quite funny, guys, and I know you understand me when I say BMI has its own limitation. Central obesity is assessed, but often without a metabolic context. And you guys know what central obesity is. That is when your waist circumference is higher. Weight is emphasized more than hormonal and inflammatory drivers. And remember in that article I wrote, hormones and these metabolic factors are going to be changing how we view diabetes, because we are digging deep into the hormonal and the inflammatory drivers that are causing people to have insulin resistance, people to have pre-diabetes. Stigma is sometimes embedded in weight focused conversation. For me, I usually say maybe there's no stigma until you sit down with people who are battling weight issues. Then you'll get to know the stigma when it comes to someone being big or someone being extra thin. Yeah. So reactive rather than preventative care. What does this mean? Care system activate primary after diagnosis, like we jumpstart or kickstart management when someone is told you have diabetes after 3 or 4 consecutive high blood glucose level. So screening often occurs once the symptoms appear. Though these days I can say where we are heading, people are assessing and really getting to capture that before we get to that pre-diabetic state, and I'm actually quite happy about that. The insulin resistant phase is frequently missed. That's why on my other platform, that is Instagram, Facebook, TikTok, I have an insulin resistant, insulin sensitivity series where I talk about various factors in our body that can cause insulin resistance, because insulin resistance is a seed that is often planted that will sprout into prediabetes and later on diabetes, central obesity, and all those other metabolic issues. So prevention is discussed later in the disease course. At least these days we are trying our best to talk about how to prevent, now how to get to that. Before we get to that phase, yes, trying to talk about or highlight the risk factors, the modifiable then unmodifiable factors, so that someone can start taking care of themselves early enough before they get to that point where the disease starts to develop. Guidelines acknowledge that late diagnosis remain uncommon, and this is very, very true. According to the International Diabetes Federation Atlas 2025, in Africa, almost 70% of people don't even know they have diabetes. They're only diagnosed later when the complication have started to arise. So the reality of this is type 2 diabetes develops silently over 5 to 10 years. Like you're just seated right here watching me looking at you through the camera, and you have diabetes. So yeah. So diagnosis as the entry point to care. So when your blood sugars have been taken and you have 3 to 4 consecutive hyperglycemic indicators, diagnosis is triggered. You're told you have type 2 diabetes or you have diabetes, whichever diabetes you have, and then now structured treatment pathways are started. So you'll go see the doctor, you'll be sent to a nutritionist and nurse to show you how to take it, how to inject the medication, how to take the medication, and all that. So complication often present at first diagnosis. Why do I say this? Like I said in the previous slide, 70% of us do not know we have diabetes until you go, maybe you have a wound that is festering and it's not healing, or you just have hypertension and all that. So when you go to be diagnosed, you are diagnosed with a complication. Then you're told you have diabetes. It's too sad. Yeah. So early metabolic dysfunction rarely identified. That's why I think on the diabetic desk, I'm going to be very, very serious when it comes to metabolic conditions. We're going to look at other metabolic conditions, other metabolic dysfunction, so that we can capture it early. Opportunity for reversal frequently delayed. This a point where last year I talked about diabetes remission and diabetes reversal. Those are two different things. For me, reversal, I believe, according to the research I've done, occurs at the pre-diabetic stage. when your sugars are starting to be high and now measures are taken into place, you're not yet told you have diabetes. Reversal is right there. But when you have diabetes, yes, there's remission. Your sugars can go back to normal, but you have to be really cautious and really careful. That is for my own academic background and what I have researched. So if you have any other um what is it called? You have any other additional things to add when it comes to reversal and remission? You can leave in the chat box. Let's talk. Prevention are historically treated as secondary because when someone threatens your line of work, I'm not pinpointing. Sometimes when you talk about prevention, people want to cure because curative there is where the money is. Yeah. We want to look at nutrition as rules and not context. For me, I usually have very weird titles, so you have to follow along for you to understand. So, dietary advice is often delivered as a restriction, traditionally, and that is what we're shifting from. Remember, this is the traditional management of diabetes. I don't know if some places are still doing it. You focus on avoid, limit, cut out until you're seated with a patient. So like some mnatuambia tutoe kila kitu tutakula nini. Culturally, food patterns is sufficiently addressed. Like I said, we are taking guidelines from the states. There was a new pyramid that was released and trying to apply it to what is it called, to the African context. We have different foods, we have different economic factors and all that. So really, Kitambo, they never used to really look at the cultural aspect of the food. And for us, food is a culture. Yeah. Economic access rarely considered. Emotional relationship with food is often overlooked. So the outcome here is low adherence and there's high frustration because if you're canceling me with a food pyramid that has foods that are eaten in another continent and I'm in another continent, I'm not going to adhere to what you're saying, and it's going to lead to uncontrolled blood sugars that are going to make me as a patient, as a client, or someone living with type 2 diabetes frustrated. Look at one size fit for all nutrition messaging. So the standard meal plans applied boldly. And that's why we are shifting from this. I'm not nitpick. Okay, I'm nitpicking. One size fit for all is really, really dangerous because it's a blanket approach. Like meal plan, I can apply to myself, can be applied to another person. And we are very different. We have different metabolism, we have different economic background, we live in different areas. So limited uh, personalization when it comes to lifestyle or work demands. Someone who's working from Django is very different from someone who is working in the office, or someone who is doing a labor intense work compared to someone who is just fully on the laptop. Assumption that knowledge alone drives change. We just give knowledge, we don't do follow-up, we don't look at other drivers that can affect someone's blood sugars. So minimal adaptation to stress or fatigue, and then sustainability was rarely prioritized. Like just go, this is my own research, just go and look at the traditional approaches to management of diabetes. You'll get to understand why this session is very, very important. You want to look at stress physiology. So historically, it was underplayed because things to do with stress, things to do with mental health were rarely acknowledged. These days, at least in a diabetic clinic, there's a mental health specialist who is there to talk to these people because managing diabetes sometimes can take a toll on someone's emotional and mental health. So stress was not routinely assessed in diabetic care. Cortisol role in glucose regulation was underemphasized. I don't know if people really knew the role of cortisol as a hormone. Chronic stress was normalized rather than addressed. Umekaa na patient anakaa tu vividly stressed, but wewe kazi yako ilikuwa tu educate and all that. So emotional load is separate from metabolic health. Like me, I'm going to just focus on the metabolic health. Emotional load, brother Dipange. Behavioral struggles are often labeled as non-compliance. Because let me give an example. I'm a diabetic patient. I come to the office. You've cancelled me, but you're not seeing change. You as a healthcare professional, this is just my own point of view. Why don't you dig deep to know maybe home I'm stressed and cortisol is influencing? I'm following what you're saying, but I'm living under duress. Why? So you not expect my cortisol ranges to be okay and my sugars to be okay. And then you're calling me non-compliance. You see, I will not even talk to you. I'll just be like, you know what, it's okay. Yeah. So sleep, they overlook metabolic factors. So sleep quality is rarely screened clinically. Let's you guys screen sleep quality. Just leave it in the comments. Let me see. Short sleep is linked to insulin resistance. You know, we encourage to have a 9 hours of sleep. So if you sleep for 5 to 6 hours, it's linked. That is true. I think I will share. There's just an article I write with some of these researchers that I've come across that will be able to explain further what I'm talking about. Cardiac rhythmic disruption is under-recognized. Morning hyperglycemia is poorly explained. You know, there's the Down syndrome. I think on my social media platform, I explained very well what Down syndrome is. And also, I think in one of my articles, where there's a period in the morning where your sugars are high because your body is waking up and all that. Go look at that video. I explained very well. Fatigue is treated as a lifestyle related and not metabolic. You know, maybe I have other factors in my body that are making me fatigued, but hey, sisi tunaangalia to the numbers, you know. So evidence sleeping less than 6 hours increases diabetic risk by 40%. So this should tell people really sleep is very, very important because I feel like this generation we do not sleep well. Mental health as a late addition, you know, diabetes, distress is historically under recognized. Like I said, mental health, emotional health, stress, well, anxiety and depression under screened. These days, like I said, in most diabetic clinic, there's mental health specialists to help with that. Emotional burnout mistaken for poor motivation, shame undermines self-management, you know, umefunzwa where kuna stress, someone, but those people are stressed. Mental health recently acknowledged in guidelines. So go look at the Ministry of Health, the 2024 guidelines for management of diabetes and mental health is in there. And kudos, you know, I'm a mental health advocate, of course. I will have to talk about this. So the consequences of this approach, usually those late diagnoses, a rising complication at presentation, like I said, patients disengaged and burnout, repeated failure cycle without the root cause analysis. Because if you're counseling the same person and you're counseling this person has adherence, the other person does not have adherence, you have to dig deep and find out what the problem is. Maybe they're just some who are stubborn and there's truly a non-compliance, and some there's just other factors apart from the numbers that are affecting or bothering the person. That's why they're not able to control or adhere to the management put in place. So the gap between clinical care and lived experience, because you want to give me or give me your clinical care like this is what I'm supposed to do, but I have a lived experience that this is not working. That's why personalization is something that is coming up, and I'm actually quite happy about that. So the turning point. So guidelines provide a strong medical foundation. Science now highlights upstream drivers. Like I said, it's just not solely about the numbers. There are other factors that I've mentioned that can affect the blood glucose control, sleep, stress, behavior, and context really matters. Yeah, very, very important, especially for someone who's a diabetic educator or someone who's managing someone with diabetes or in a diabetic clinic. Very, very important. Prevention must begin before diagnosis. That's why we are here as the diabetic desk, founded by me, where we are talking about these issues before the diagnosis. So I am encouraging you guys to turn into a healthy lifestyle so that we don't get to that point. We tackle insulin resistant before it gets to pre-diabetes, which can lead to development of diabetes. Education must explain why and not just what. Let's somewhere because these people are well read. They research and they know. So you have to set yourself aside by looking at all these other contexts so that you can know what to do. So blood sugar numbers tell us what is happening and not why. Because if I'm having an HbA1c of 12%, it shows I'm not managing the sugars right. We have to probe deeper to know why. It might be stress, it might be my sleep quality, it might be my behavioral change, and the context I'm in. Maybe I'm in a